have this social determinant platform to round out that longitudinal health record for that person. So I am going to ask Angela and Brian to go ahead and kick off the demo for you in the slides. And I'm sorry, I should have backed up and done introductions. So also on the call with me today is Shelley Miller, who is our Director of Clinical Applications, Angela Green, who is our project manager for the work, and Brian Longo, who is joining us to help us from the Unitas side and has been our point of contact for the Unitas. So Brian, I'll turn it over to you, or Angela.
Yeah. Okay.
Brian, are you able to share?
Yes, I am. Let me go ahead and start sharing my screen. Give me one moment to do so, please.
I'll let you introduce yourself, Brian. I know I did not get your title right.
That's okay. So hi, everyone. Brian Longo, Senior Manager of Discovery and Enablement at Unitas. Unitas is a technology partner, partnered with NEHI as part of their social determinants of health initiative that we're calling Unite Nebraska. Let me go ahead and share my screen here. Excellent. So as we present today, feel free to stop if you have any questions. We'll take breaks in between probably every other slide. And then if we have time for software demo as well, depending on the discussion, we can do that as well. And so Melanie and I will co-present this presentation for you all. So our agenda, pretty quick here, knowing we have limited time, we want to show you, talk to you all about the initiative, about the network, what our goals are for the project, the scope and nature of the project. We want to review the software, talk to you all about how clients and patients and those seeking services could be served through our network, and also give you some indication of what's to come for the project in terms of timelines, in terms of where we're rolling out and how folks will get access to the platform, and even give some hint to who we've already started talking to, and you all are one of the first groups we're presenting to. So super excited to be with you all today. Melanie, you want to lead off with why we're here?
Sure. So what happened was about a year ago, in working with NEHI, is about when I joined the team, we started looking at ways that NEHI could look to use funding sources that were available through NEHI, through our federal and state partners, to make something like this available to us. So we really felt that one platform statewide where everyone could collaborate together and surround that person with those resources they need, as well as be able to see what the other organizations and community entities were providing in this space, would be a huge value to how we address the social needs of everyone that we're caring for across the state. So we looked for this solution, we did an RFP, and are pleased to know that we selected Unitas. This has been an amazing platform and a great partner to us. But what we really wanted to do was create something that was a one place and space for all of our healthcare services, all of our community entities, our social service partners, really in every space, where we could all work together. The other thing we kind of have been trying to do is create a visual of, on the side here that's blue are all the very normal things that have been coming into NEHI, all the basic clinical records, you know, labs, emergency records, different things like that are all very normal clinical types of information. But what we're also looking to build out is this side where it's that red, getting into that community space, working on this project, working with our government agencies and trying to get that information also brought into this record. And then when it comes out, it'll be the HIE and our prescription drug monitoring program together, along with the social determinants of health, that ultimate goal is to have that one longitudinal record that captures everything together. Back to you, Brian.
Absolutely. So just some quick information about Unite Us, who we are as a company. We are a technology-enabled services company currently active in 35 states across the country, and we partner with organizations like NEHI, organizations in healthcare, from health plans to health providers to HIEs, organizations in the community, from United Ways to really any conveners there are in the social services space, the community-based organization space. And we also partner with local government, state government, and federal government in different places, ultimately to do projects just like this, where we're helping to create the infrastructure, the common technological infrastructure to connect individuals seeking help to those services. So really you can think of who uses our platform. Anyone who provides health and human services could be a potential user of our software. I'm going to show you exactly what that is in just a moment. So as Melanie relayed, our vision for this Unite Nebraska network is to create a coordinated network across the state of Nebraska and into some contiguous regions, designed to connect all of these different entities, social service organizations, government partners, and healthcare organizations as well, to deliver an integrated and whole person care through this shared technology platform facilitated by Unite Us. Ultimately, the tool allows users of the platform to send and receive secure electronic referrals, to more securely share client information, to track outcomes related to those individuals seeking services, to those patients and to those clients seeking services, ultimately to say, did they get connected to a service provider, but also to go a step further and say what happened to the individual at the end of the day. And then the last piece here is to provide data and information designed to inform community-wide discussion. So it's data and information that is accessible and will be available to different participants at different levels in this network. Everything from information that is operationally useful to a care manager or a care coordinator trying to help a person, but also all the way up to the strategic level when we're trying to understand how are different individuals across our state being served by all of our different organizations, both in healthcare and in the social services, social care side of the house. So who's involved in this project? Today, we have NEHI as the primary funding partner. They are working to catalyze these efforts to provide strategic guidance for the Unite Us team and for the project as a whole, and overall to promote platform use and network growth. In the middle, we have our healthcare and our community partners, and that's really everyone who's, I think, on the phone today, everyone in the community who works and lives and does this work every day. Traditionally, in our network model, they play two different types of roles. One role is as a user of the platform to send and receive those referrals, to share client updates with the network in real time, and they can control and monitor their own organization profile within the software. The second piece here is to partner with all of us in how best to implement this network within their own regions, within the places you all work every day. So that's very much a part of this process, is working hand in hand with our partners, both in the community and the healthcare side, to have them tell us how best to implement this network and this model within their own program offerings, within their own strategy as an organization, and within their own communities, knowing those communities best. So it's very much a community-driven and partner-driven initiative. The last piece here is Unite Us. We provide the technology to support the infrastructure, to support the exchange of information and those referrals. We solicit ongoing feedback from partners. We work with the NEHI team to monitor data and make the data accessible to partners. And overall, we work hand in hand with the communities to promote the platform use and network growth. So we're actually hiring staff on the ground in Nebraska, folks who have either worked or lived in the communities or have worked and lived with our healthcare institutions before and who know them really well, who bring that subject matter expertise to the table and can then act as guides to the network rollout and work alongside everyone in this process to roll out the network. So we wanted to touch on privacy and security for a moment. I know I'm talking a lot about information exchange, a secure information exchange. So we wanted to talk about how we make this a reality. Unite Us is a HIPAA, FERPA, 42 CFR, SOC 2 compliant system that does allow for the real-time exchange of client information up to and including that more sensitive PHI information. The way that we maintain this compliance is a number of different ways, but one of those ways is this consent process, which is facilitated through the technology and allows users of the platform to acquire a client's consent in real time through the system before their information is shared. We also have permissioning mechanisms that allow us to silo different types of information to ensure that they can be shared with a service provider who is applicable to that client's need, who should have access to that information, but is not more generally available to all the members of this individual's care team, all the members of the community who may be working with this same client to service them. So happy to expand on that piece. If you have any additional questions around consent, I'll keep going, but feel free to post them in the chat. We can also spend some time with Q&A at the end.
Brian, it's Melanie. I do want to tell the group that this was one of the reasons we selected Unitas as a platform. They offer 6 different ways to obtain consent. And from my years of work in this space, obtaining consent was something that actually created a lot of, it slowed down the process. But with the options that we have through this platform, we can obtain consent through someone's cell phone or email in a matter of seconds and move forward with that referral. So this is one of the items that really drew us to the Unitas platform.
Thanks, Melanie. All right, so we've talked, I think, a lot about high-level concepts and goals so far. We want to get a little bit more operational with you all for a moment and show you a client journey through the network, talk you through the workflow and kind of the value proposition of the system for users. So let's say we have a client and they walk into your offices and you recognize through conversation with that individual that they have a need, falls outside of your wheelhouse, what you do at your organization. Using the platform in Unite Nebraska, you'd be able to send an electronic referral through the software, digitally capture that client's consent to share their information, and then using information you may already know about that client, their first name, their last name, their date of birth, and what they're looking for, you can send that information directly to a service provider who would also have access to this closed loop shared infrastructure system. From there, that organization would contact the client to begin receiving services. And additionally, if they had a conversation with the client and recognized more needs were present in that individual's life or for their family, they could send electronic referrals out to those different organizations. And from there, those organizations, again, could log into their Unitas system and access referrals for those needs. And then again, could reach out to the client to engage them and receive those services. A key difference for our software here than other resource directory type tools that may facilitate referrals is that each of these individuals, the care manager, the food assistance provider, the employment provider, and any of these other organizations, all have access to a shared client record that will show them that linear journey, that history, this journey we can see depicted here for us along the way, and will give them insight into what's going on at these other organizations, again, within the confines of information and permissioning that's applicable with under law, but also really valuable and helpful to have that situational awareness of the different needs this client has and how other providers are working with the same client. So a few differences here for a traditional referral, a referral done over the phone, fax, or via email, and a referral done through Unitas and the Unite Nebraska network. The first is today, it's hard to exchange information sometimes. We have clients, we have patients, we may know their story or we may know a piece of it, and that information may be really relevant to getting them connected to a service provider, but ultimately it's hard to exchange that information, as Melanie was just saying, on behalf of that client. Through our platform, because it's secure and offers these different consent methodologies, it is easier to exchange that information and more secure to exchange it than via email or fax or on paper. Second, today it can be really hard to match a client based on the individual that you're serving and all the resources that are available in a given community, all the different nuances that go into matching that individual, things like eligibility, capacity, and geography restrictions. Through Unitas, there are tools, filtering tools, and other mechanisms that will allow you to more easily match a client that you're referring to the service provider, to the best fit service organization that they may qualify for. Third point here, today in a traditional referral, unless we're performing a really warm handoff, we're calling an organization with our client or our patient while they're on the phone or they're with us, it's ultimately on the individual who's seeking services to engage with and to reach out to an organization. Through Unite Us, we're trying to change that onus, take it back into our hands as service providers and then share that client's story proactively on their behalf and then allow a service provider to reach out to that client and say, hey, Mr. Smith, we know you have this need. How can we help you address that need? The fourth point here is around insight. It's hard to know, did my client actually get connected to those services when they leave our four walls? Through the platform, you're going to be able to see that the client was successfully connected to that service provider. You'll be able to track that client journey, and then you'll be able to go a step further and see not only did they get connected to that service provider, but the services that they received, and also the outcome that's recorded at the end of the day because you connected them through this shared network. And the last point here is around data and information. If we're all tracking data in different ways, we all kind of have a different piece of the client puzzle. And then that transactional data is not really tracked at scale today across the state or even across a city. It's hard to know who are all the different organizations that are outside of my company, my organization, that are working with the same client. And so our goal is to create that longitudinal record and to make that longitudinal record shareable and accessible, ultimately to inform decision making by those operational folks, those tactical community care teams, people who are on the ground working, and also by communities who are saying, what does service delivery look like across Omaha today? How does it work if you go from North Omaha looking for services and you travel somewhere else in the state? Can you track that same individual and see all the different needs they may have over time? Let me pause there for just a moment, and I'm being conscious of our time, about 10 minutes left, I think, for us. Any questions for Melanie or myself?
Yeah,
So
we're trying to coordinate the Nebraska, we're trying to coordinate the Nebraska total care.
I see a few
Here.
questions in the chat.
Do you want me to read those, Brian?
I can go ahead. It looks like one of the first questions is, will there be a cost to use the Nebraska tool, or will it be included in our knee-high fees? Melanie, I'll let you take that one.
Certainly. If you are a participant with knee-high right now in data sharing, this comes to you as part of the platform. For any groups that are outside of that, we would love to have you data sharing with us so that this could be part of those services that we offer to you. But we do realize there'll be some unique organizations that if you just contact us, we'll figure out how we can come to an agreement on what that would look like between us, because our goal is really to have as many in the state available and using this platform with us together. So this is part of your knee-high if you're already data sharing with knee-high. And then beyond that, we're open to any discussions.
Excellent. It looks like the second question is, if this is available through knee-high, will this change the process that patients will need to opt in to have their information shared to knee-high from facilities/clinics? The current process is that patients need to opt out and call knee-high to not have their information shared with knee-high.
Correct. Nebraska remains, has that same opt-out condition applies, but in this particular platform, every person is consented. So this will stand alone outside of that because that consent before referral is made is captured. So there may be someone who opts out of sending their data to knee-high, but still wants help through this platform, and that can be done because their consent is obtained and captured within the platform itself.
There's another question on chat. It reads, using this platform, what percentage of service matches are typically achieved for clients? And I would go further to say specifically in rural, how successful has it been in matching?
Yeah, so I think it's certainly variable depending on the community, and even as we just pointed out, the geography and makeup of that area. So for rural communities, we know there's a scarcity of resources. And so what the tool does and what we've seen is it really highlights the scarcity of resources that exists, that in some cases we kind of have said to this point, anecdotally, we know there's a scarcity of resources or we have trouble finding resources, but the platform helps us to capture the needs that clients are expressing. It allows us to send referrals to what resources exist, and then also to capture if those resources that exist are not able to successfully serve that client, why that is, whether it's a capacity gap, a funding gap, or simply geographic restrictions around their service delivery. Maybe they're actually not proximate to a client and they couldn't get there because of transportation inaccessibility. So that's what I'd say here is that the platform does a good job of helping to raise those gaps and make them more visible and quantify them for a community. I think the percentage of match rates is going to vary pretty significantly depending on different communities, the availability of resources, and even the maturity of the network, knowing that it takes time to build out a network like this across an entire state. Another question was, how do community resources get on the platform? Community resources are engaged in the platform in one of two ways. The first way is what we call in-network resources. I'd say that's the bread and butter of what Unite Us does. Those are organizations that actually have access to this tool. They are socialized and brought on as part of the onboarding process. I'm sorry, just going back here. They're socialized and brought on as part of the onboarding process, and they have staff and users who have access to the platform. So they can receive those closed loop referrals through the system. They can respond to them. They can exchange information about service delivery and send referrals for their clients and things like that. The second type is what we call out-of-network resources, and those are what you think of like a traditional resource directory, a directory comprised of organizations that are listed, are available to reference, are available to share with a client. You can share the information, but ultimately they have not yet opted into participation in this platform. And so it's like any resource directory, a static list that can be shared with a client, but ultimately you won't have information about if that resource was successfully achieved unless you ask the client or call the organization. So our platform supports both of those two methods, but the goal ultimately of our system is to have as many organizations come on board and use the platform, turn into in-network resources as we can. So I do want to be conscious of everyone's time here and our next presenters, and just hit on our last slides here, and then we'll have plenty of time for questions as well. So we wanted to touch on some data and reporting that is available in the platform, or also through our platform called Unite Us Insights, facilitated by Tableau. So the platform itself has reports around demographic and contact information, referral traffic, top referral senders and receivers, and outcomes that are recorded. Our product through Tableau, called Unite Us Insights, also has similar type information at a higher level for the entire network, and also is filterable, as we see here, by county or by region to help see insights that are specific to a given community. So I've listed out some data points that we typically report on here, things like the types of organizations and users who are accessing the platform, where they're located, and even the types of referrals that are going outside of the network, what we call like out-of-network referrals, those traditional resource directory type referrals. We have information around our impact as well. So how many clients are actually being served, how many service episodes are being created, so what types of needs are our clients expressing, and how are we matching those needs, the average time for referrals to be accepted, how many referrals are being rejected and for what reasons, and then the outcomes that are being recorded, how many of those service requests are being closed out by each of those service categories, and the types of outcomes that are being recorded. So these are reports that will be a part of the platform, or available to NEHI and to network stakeholders in different ways. And I think they can tell you a variety of different things depending on what you're interested in. So we did want to give you some practical information here about our plan of action. This is our network rollout timeline. You'll see a fairly aggressive 1.5-year deployment schedule here. Our goal is to start, well, we've started already, I should say, as of May, but to go live in our red region on this side of the state, in the Omaha Council Bluffs area and Lincoln area by September 23rd, 2020, knowing that it will be an ongoing iterative process to continue to build out in that area. Our second area is down the middle of the state, our third down the southern portion of the state, fourth in the north, and then fifth out west. So a goal of having the entire network be live by July 30th, 2021. Again, taking into account that the network building process is iterative and takes time to get organizations bought on. And we're already having conversations with a variety of different partners in the healthcare and the community space about their own timelines, about their own process for onboarding into the network. So we did want to, yeah, absolutely.
I'm sorry, Brian. The only thing I wanted to add was a couple quick things. So if you are currently data sharing with NEHI, the way this platform is going to work is when you log in and you search for a patient, it's actually going to search against the NEHI database and bring that information forward. So your patients should be loaded there if you're trying to do that, and that will cut down time. You can certainly add new, but we wanted to let you know that we're going to do everything we can to build the platform out in a way that facilitates ease of use. And the other thing is, as we go across the state, we will be looking to go into our border counties, not just Council Bluffs, but throughout the whole state, because we know that care moves back and forth across those boundaries. So for example, in northeastern Nebraska, of course, you're receiving care in Sioux City and North Sioux City, and so we will be engaging them as well and bringing those resources into the platform.
Any other questions before we wrap up?
I don't see any new ones in the chat. Does anybody else have quick questions for the team before we move on?
Well, thank you,
Oh,
everyone.
think of them. You can send them and I will pass them along and we can get you answers later too. So,
Excellent. Well, thank you, everyone.
That's great. Thank you.
thank you. Okay, now we're going to move on to H4 Technologies, and I will let them introduce themselves too, and I will turn it over to Craig if he's ready, and we'll let them move into their presentation.
Yeah, thanks, Margaret. Let me share this out, and hopefully you're able to see Social Determinants of Health Compass H4T logo.
Yep.
All right. Well, thanks for the invite to talk to you guys about social determinants of health and what we're doing to address and help with the technical aspects for communities that are addressing these needs. I wanted to go through a couple slides here and then show you our demonstration. As we look at social determinants of health, there's a variety of items there that you guys are looking at. The first piece is the data element. So there's patient demographics, EMR data, then a variety of assessments. So RCI is one we're going to be talking about today, but we have a variety of other ones, the AHC, HRSN, as well as there's behavioral health assessments out there for addressing SDoH. Once you get the data in, then we can help analyze and predict those patients that are most likely for readmissions or ER visits. Through that patient identification process, that's where we, on the assessments, get the information back and identify the SDoH need. So whether that's housing, food insecurity, transportation, those are common ones. Then we have alerts and notifications on that data, which I'll show you we can facilitate some patient engagement activity there. And as the Unite Us guys obviously are doing a great job on the community resources directory. So what we've done for the behavioral health population is we're integrated with the Department of Behavioral Health and are doing community resources for behavioral health clientele. So we do have a platform for identifying the behavioral health population, but as a broader scale, the Unite Us platform, with getting the community resources involved and doing the referrals and having that network built into NEHI is a great resource available to the state. So we can talk about little pieces and parts of that on how we can help out. So our Compass SDoH solution, it's a SaaS-based platform. We have over 3,000 users, 2,300 providers, and a little over 1.5 million members. The flagship clients that are using it are the Nebraska Department of Behavioral Health, Colorado Department of Behavioral Health, and then we, in a partnership with Face It Together, are now expanding this RCI platform out to anyone that is looking for an SDoH solution. As you guys are looking, I guess a lot of conversations start with, okay, how do we identify, what assessments do we use, and what are you doing in your community besides the community needs assessment to look at this on an ongoing basis. So there's customized and standard assessments out there. We can add new ones. We've got over, I think, 12 or 14 now developed, and all that flows through into the database and into the analytics product as well. So from our standpoint, the newest assessment we have is the RCI. And so the RCI framework models social determinants of health. And I invited David Whitesock, who built the RCI assessment, on the call. So if he adds information here. But I wanted to share what we're doing here. So this is a holistic assessment. So you're looking at 3 different areas of the person. So social capital, so that's family support, significant other, social support, mobility, healthy lifestyle, access to healthcare, safety, physical capital, so general health, mental well-being, nutrition, employment, education, housing, transportation, clothing, and then cultural capital. And this is the area that I think really, this RCI really breaks out and expands as you're looking at beliefs, spirituality, sense of purpose. Are people ready to, not only which areas do they need help with, but are they ready to move forward with that help, right? And so as we're looking at expanding to this whole person care, these type of items can be tracked and can be our data points within the assessment to be logged and analyzed as people continue and seek more and more treatment and more services within the community. So there's a variety of SDoH domains and indicators within the framework that helps out. So there's ICD-10 codes. There's other, protocol for responding to and assessing patients' assets, risks, and experiences. And then there's health leads. And so these are areas that we can help track and share, I think, with you guys and NHA and the general group. So as we look at the RCI itself, it's comprehensive. So it's 68 questions, takes generally 5 to 10 minutes to complete. It's a 100-point scale, and then we're doing 30-day intervals automatically. And so we're reaching out and continuously monitoring patients and consumers throughout the year. And that's where, without throwing staff members at it or phone calls or some other system, this is automatically doing this for you. With the assessment, it provides, one instrument to provide you a high level 30,000, a macro view, or we can go down to the micro elements. We call them subscales in our system, but to identify each one of those needs. So we can look at the individual, inform personal care and support, track change, maybe the organizational level, identify program needs and measure long-term outcomes, and then community level, maybe map deficits, help you design solutions, and effectively allocate resources. So if you're seeing that there's an uptick in, most people have a food bank or food program, but maybe there's some other need out there, a housing authority or whatnot, and then we can provide, the community or the assessment to provide the answers to identify those gaps in your community and to help you align the resources in your community to that. So when we're looking at the RCI, and we can do this for any assessment, is the mobile delivery aspect of this. So we are mobile enabled and I guess email enabled. And the RCI is automatically sent to a patient's email or phone via SMS-based preferences and when they're signed up and completed online. And so people are able to take this survey or assessment over their phone. They don't have to go in to the hospital. They don't have to look at, they can get email, but in my life, email just keeps getting bigger and bigger, and I'm losing things. So this is a SMS text-based delivery. What we're finding with this, I just did one, I don't know, an hour ago here, right? And so my client or my consumer is Mike Christensen. And so I got the text, boom. Hey, hello, Mike, please take a few minutes to complete the Recovery Capital Index, the RCI. I click on that. There's my text information, click on the link, and then here we are into the web-based portal. You'll see up top, you have the 3 different categories. So personal capital, social capital, cultural capital. And then we have the scale, the Likert scale 1 through 5. And then they progress through the assessments. Now, everything is saved automatically. And then there's provisions in the system. They can't retake the same assessment if they already completed one. And then there's reminders throughout that we can set basically up to 7 days to remind them to take it. So this is how you can reach out to those consumers and patients outside of your 4 walls, to get information and talk and get feedback from them. So what we're finding, and there's information out there, but email and text, reach patients where they are. 90% of the U.S. population owns smartphones. It was 99% of texts are read within 3 minutes. And then 79% of Medicaid patients are more likely to use text than private insured individuals. And there's a variety of metrics and reports out there. This one was from NIH, National Institute of Health. And then additionally, according to Pew Research, when individuals were presented web surveys, there were more opens through text and email. There are more opens and completions than just one or the other. So then we take the data points, the subscales, we identify the items, and then we load them to our business intelligence tool. It's within the product. So there's unique participants. You can look at total RCIs, employment status, gender, marital status, and then the on the right is that the actual average monthly scores, and this can be done for the RCI as well as any other assessment. When you're comparing it to the others out there, other assessments I've seen might only be 7 to 10 questions. That's a great start and a great avenue to find maybe certain high-level social determinants, but when you're looking at total well-being, this goes just a whole nother level in the data that it is capturing. Through the tool, then, we also have the self-service reporting. So we got standardized dashboards, and then if you wanted to dive into your own data and look and create and share and maybe run a list or do whatever, that's all included in the platform as well. So when I'll jump into a kind of a demo here in a few minutes, but this is a SaaS solution. We're basing it on a per provider fee, and then it's part of the NHA services partner, so it qualifies for, I guess, that partnership. So I'd like to, before I jump into the demo, are there any questions on what I went through so far?
I don't see anything in the chat right now. Anybody have questions? No, I guess we can move on in.
Okay, perfect. Let me pull this other screen over 1 second. multiple screens. Yay. Okay, so we have our web-based system. You log in. This is our test environment for the RCI. As I'm looking at, I can look at consumer-based metrics. I can search for consumers. I have my provider, Mike. I just admitted him today. And here's where we can integrate with EMR or other data sources to capture status. I can capture consumer information. I can look at demographics. I can really see what pieces are being captured, as well as the scores. So in my status, I can view the recovery capital score. Here, this is the printout view. So if someone's actually there in your at your facility, you could monitor these and then print this out and hand it, to the person. Additionally, then we're tracking and trending these data points over time. Everything that is captured is then analyzed. So each one of these buckets, so if you see basic human needs, if you see social capital, social mobility, access to healthcare, those type of things are all being captured and saved. And so this has, once I set up a consumer, capture their email or integrate their email or their phone, then I have the ability to send out the assessment. So if I wanted to add an assessment, I can add this. I could fill it out here. If I wanted to go back to the consumer, I could on demand send a survey now. That'll create, are you sure you want to create it? Okay. Boom. Maybe I'll turn on my camera for this one. So on this, we'll have, this is that new survey link I just created. It has the expiration date. I can copy that link. And here's where I am able to fill out my survey, take it over either on the mobile or online, and then you can see the progress bar of the different groups. And so these are the different entities. Generally in a demonstration, I send the text to the individual that we're demoing to, just so that they can play with it. On all our test systems, you'll generate a RCI assessment for the next 3 days to simulate the 30, 60, 90-day initial buckets. The assessment is ongoing, so they'll continue to get that on that 30-day basis as long as they're enrolled in the program. To unenroll them is simply basically a discharge of that patient consumer out of the system. So as I'm filling these out, I'll show you just the different elements and whatnot. And on these different groups, we can walk through this. And when I'm done with the assessment, I'll show you the results. So when we're talking with hospitals and rural providers, that generally do a community needs assessment, then what we end up seeing is that we have, that community needs assessment might be something that is provided once a year on a individual basis for the community. And then what ended up happening is that might get populated and produced for the hospital, but it might not be ongoing in a monthly or weekly, I guess, process. So they'll look at that, and then generally they might do it every other year. And so this is a way to identify those needs and look at that individual on an ongoing basis. So. Any questions on the assessment itself, the metrics that we're capturing? Everything will be assessed over time, so you can see the trends and consumers that need those assessments, and then need those resources, and then we can look at either look them up in NEHI or provide the variety of resources you might have locally. So.
Does anybody have questions? No. Okay, well, we will wrap up then. We have our next webinar on July. I'll have to look.
I do see one question out there. This is Tony.
Oh, did I miss it? Let me get back here. So how does the Unite Us and this work together?
Craig, do you want to take that or?
Yeah, currently we are, we work with DHHS and other groups. We can incorporate and integrate data from NEHI as a process. We currently, I think that's not live or anything. And so, that would be an undertaking we'd have to do. But this would be, I just based on the looking at the presentation from before, I could see how these things could go hand in hand with identifying the people and then pushing them over to the referral process.
Yeah, that's exactly the way I see it.
So,
Greg, this is Melanie from NEHI. I would agree with you. I think there's nothing but opportunity for us to collaborate and build a stronger relationship because, as you know, no one has one specific need. It always seems like there's multiple things that if we're working together, we could be more comprehensive in what we're doing. So I'd welcome an opportunity to visit with you.
yeah, that'd be great.
Any other questions there?
Yeah, last thing I'd want to say is we have 12 assessments built today. We had a demo with another group, another HIE actually, Melanie, last 2 weeks ago, and they have their own, or they had a specific one they wanted to use for a specific grant. And so we talked to them about adding that. So we already have the framework built. I'm promoting the RCI and the ones we have because I think the completeness of what we're doing is there and has value. But if there's some program where you need a specific assessment, we can easily add that. It's configurable in the system. We can add that assessment to the platform. You could use that. You could use the RCI. You could use a variety of them. The states are using multiples for a variety of patient settings. So just keep that in mind.
And Craig, one more came through. Do you want to talk a little bit about the cost structure of your product?
Yeah, right now we are individually selling and working with providers. The yearly cost is $6,000 for the platform per provider. That's unlimited users, unlimited patients in the program. And then we are, if you had obviously scale or whatnot, or multiple providers in a area, we could obviously work with you guys on that. This is a SaaS-based model, so we already have it built, barring you use the assessments we have, and there's really little configuration that's needed besides integrating the data points. So.
Okay. Well, I don't see any other questions coming through, so we will wrap up. Our next webinar will be on July 8th, and we'll talk about kind of the medical record documentation, Z codes, coding, things like that on social determinants of health. So that'll be coming July 8th. If you have questions that you have for the two presenters, you can either reach out to them or send to me and I can move those along. And I guess that concludes today's presentation. Thank you everybody for listening, and thank you to the presenters for the great information. And we will see you next time. Thank you.
Thank you.
Thanks.